Hello and welcome to Allocating Ventilators in a Pandemic. This is a socialized remotely signature event brought to you by Harvard's Office of the Vice Provost for Advances in Learning, Harvard Medical School, and socializeremotely.harvard.edu. As the current pandemic unfolds, many have been concerned that our hospitals may not have enough ventilators for all who might need one. Although it now appears likely that the supply will be sufficient for the time being, the future remains uncertain. And this is a good opportunity for a societal discussion about how hospitals will decide who will receive a ventilator and who will not if these decisions ever become necessary. Let's introduce you to our speakers for tonight's event. Dr. Robert Truog is the Francis Glessner Lee Professor of Medical Ethics, Anesthesiology, and Pediatrics, and Director of the Center for Bioethics at Harvard Medical School. As Director of the Center of Bioethics, Bob has overall responsibility for the center's many activities, including the Master Bioethics Graduate Program, the Bioethics Fellowship Program, required courses in medical ethics and professionalism for Harvard medical students, and the center's many workshops, seminars, and public forums. Bob also chairs Harvard University's Embryonic Stem Cell Research Oversight Committee, has published a book on death, dying, and organ transplantation, and has had a 30-plus year career at Boston Children's Hospital, where he practices pediatric intensive care. Dr. David Jones is the inaugural A. Bernard Ackerman Professor of the Culture of Medicine, a joint position between the Faculty of Arts and Sciences and the Faculty of Medicine. David has a distinguished research career exploring such topics as human subject research, Cold War medicine, HIV and other sexually transmitted infections, and the history of decision-making in cardiac therapeutics. Trained in both pediatrics and psychiatry, David has won teaching and undergraduate education awards from both Harvard Medical School and MIT. The third of our speakers, Dr. Mildred Solomon, is the president of Hastings Center, a nonpartisan, nonprofit organization of research scholars that over the last 5 decades has helped establish the field of bioethics. Millie is both a bioethicist and social science researcher whose scholarship is focused particularly on the ethics of end-of-life care for adults and children, organ transplantation, protection of human research participants, responsible conduct of research, and the governance of emerging technologies. Millie also serves as Professor of Global Health and Social Medicine at Harvard Medical School, where she directs the Fellowship in Bioethics. Joining our speakers is our moderator, Dr. Scott Bateman, Professor of Pediatrics and Anesthesiology at UMass Medical School and head of UMass Memorial's Office of Ethics. Scott ensures that the office provides effective consultative services and support for a wide range of ethical concerns related to patient care, including informed consent, surrogate decision-making, goals of care, organ donation, end-of-life care, and medical futility. Scott also serves as medical director of UMass Memorial Medical Center's Pediatric Intensive Care Unit and is a fellow in bioethics at Harvard Medical School. Without further ado, let's begin discussing allocating ventilators in a pandemic. Bob, the virtual floor is yours.
Okay, well, thank you, Jonathan, and thanks to everyone out there who is joining us. I appreciate your being with us. I'm looking forward to good discussion with my friends and fellow panelists here, as well as with all of you. The idea is that I'm going to give a short slide presentation about where we are and how we got here, and then we're going to turn to some of our other panelists and then to your comments and questions. Allocating ventilators in a pandemic, where are we and how did we get here? So the story begins New Year's Eve of last year when there were a cluster of pneumonia cases that were reported in Wuhan, China. And exactly a month later, the World Health Organization declared the coronavirus as a global health emergency. By the middle of February, Italy was seeing a surge that was really quite a problem. And later on that week, we had the first confirmed US death from coronavirus in Washington state. As we moved into mid-March, the CDC was predicting that we were going to have a shortage of ventilators and began issuing advisories for that, including recommendations for ethical considerations to inform how this scarce resource is provided to facilities to save as many lives as possible. And the following week, we started to see a lot of articles in the medical literature, as well as the New York Times, beginning to discuss how ventilators would be allocated if necessary. On March 26th, the US became the world leader in coronavirus cases. And that evening, that was a Thursday evening, we had the first meeting of the Massachusetts Department of Public Health Task Force to develop crisis standards of care for Massachusetts. And we worked pretty much continually up until these were published on April 7th of last month, with revisions being published on April 20th. So the good news is that it appears that we are likely to have enough ventilators without enacting crisis standards of care in Massachusetts. But we have had a shortage of many other things, some of them life-saving, such as dialysis machines. And indeed, a couple of days ago, the New York Times reported the first death from a patient who was unable to get access to dialysis. So when we look at where we're at, I thought it might be interesting to ask what we might be able to learn from the past. And I want to tell you a little bit about the story related to the invention of renal dialysis in Seattle in 1961. So that year, a team of scientists and physicians developed the technique for creating vascular shunts and the machine for performing dialysis. But Seattle could offer chronic dialysis to only a few patients. And so the question was, how should they choose? The King County Medical Society appointed a committee of 7 people to make these decisions. It consisted of a lawyer, a minister, a banker, what they called housewife back then, an official of state government, a labor leader, and a surgeon. The following year, there was an article published in Life magazine, which back then everybody read, describing the activities of the committee. Almost, you might say, an expose, really, by Shana Alexander. It's become quite a classic news story. And as she reported, the committee's selection criteria that they developed were to look at the age and the sex of the patient, marital status and number of dependents, patient's income, net worth, emotional stability, educational background, nature of occupation, past performance and future potential, and the names of people who could serve as references. So for the magazine article, the committee recreated a conversation that they had from an earlier meeting. And so here is the recreated conversation, if you will. The lawyer began by saying, the doctors have told us that they will soon have 2 more vacancies at the kidney center. And they have submitted a list of 5 candidates for us to choose from. So they had to choose 2 from among 5. So the quote unquote housewife said, well, if we are still looking for the men with the highest potential of service to society, then I think we must consider that the chemist and the accountant have the finest educational backgrounds of all 5 candidates. Surgeon said, how do the rest of you feel about number 3, the small businessman with 3 children? I'm impressed that his doctor took special pains to mention that this man is active in church work. This is an indication to me of character and moral strength. The labor leader said, for the children's sake, we've got to reckon with the surviving parent's opportunity to remarry. And a woman with 3 children has a better chance to find a new husband than a very young widow with 6 children. To which the surgeon responded, how can we possibly be sure of that? And indeed, this is the person that they selected that day, John Myers. He was patient number 3, the father of 3, whose life literally was saved that day by the decision of the committee. So I think we'd all agree that that probably is not the right way to decide who lives and who dies. So let's fast forward to the present day, and let me tell you a little bit about the framework that the Massachusetts Department of Public Health has come up with. The framework is based largely on the work of Doug White, an intensivist and ethicist at the University of Pittsburgh. He's been working on this for a number of years, and one of the strengths of the approach is that it was created with intensive input from diverse citizens groups and disaster medicine experts. Another strength is that there's no categorical exclusions. Everyone is considered a candidate to receive a ventilator. In other words, in this framework, there's no such thing as a life that's not worth saving. So in terms of principles, should the quality of a person's life matter? Should we talk about quality adjusted life years, et cetera? And for these principles, absolutely not. But should the duration of the person's life matter? And this is remains a very controversial point. Some would say no, that everyone should have an equal chance no matter how long they may survive. But for others, whether someone will survive for a few months or for many decades does seem ethically salient. So the guidelines take a compromise position and include the probability of what's called near-term survival, which is defined as the probability that the person will survive at least 1 year and that the probability that the person will survive at least 5 years. So to put this in perspective, what this means is that a person with a predicted survival of 5 years will have an equal chance as a person with a predicted survival of 60 years. So it's a compromise position between not considering duration of survival at all and considering it to be the most important thing. The strategy is based on two components. So the first is in-hospital mortality, and that's estimated with what's called the SOFA score, Sequential Organ Failure Assessment Score. And then, as I just mentioned, near-term mortality, which is estimated as risk of mortality within 1 year and 5 years. So let me show you the actual score sheet and how it works. So a patient would come in and the triage team would perform the scoring. And so in this case, lower numbers are better. So if the SOFA score is less than 6, it means you're relatively healthy and you only get 1 point. And as the SOFA score goes up, you might get 2 points, 3 points, or 4 points. Then we turn to near-term survival, and you get 2 points if you have a condition that will, with death likely within 5 years, or if death would be likely within 1 year, you would get 4 additional points. So everybody would be on this scale between 1 and 8 points. And then, depending upon your number of points, you would be put into a priority category. So if your score is low, say 1 to 2 points, you go into red, which is the highest priority for a ventilator. And as your number of points goes up, your priority category goes down through orange to yellow, which is the lowest category. And green is on here, but green means is that you don't need intensive care. So you're not a part of the system at all. So that's how it works. I want to close by mentioning several major challenges and unresolved questions. The first, I think, and undoubtedly the most difficult, are the legitimate concerns regarding people with disabilities. How will life expectancy be factored in for them? Issues of implicit and explicit racism. This is an article that was in the Boston Globe a couple of days ago, a tragic case of a young woman who died without receiving the care that she should have received. And clearly, you know, issues of racism are at play here. We also have to wonder, how do we deal fairly with patients who are disadvantaged by comorbidities associated with socioeconomic status? So we know that, you know, diseases like hypertension and diabetes are going to be more prevalent among the poor. How do these get factored in? And I'm sure we're going to talk a lot more about that as the hour goes on. Another question is whether we should give preference to the young. And when we talk about this, people often refer to the life cycle approach. The idea here is that everyone should have a chance to experience all of the cycles of life, if you will. A 60-year-old, for example, has already had a chance to be a young adult, whereas a child has not. Now, in the literature, this is often considered not to be age discrimination, right? Because the older person has already received what the younger person desires. But in different states, as these have developed, this has been handled differently. Another very hot button issue is whether healthcare workers should have priority for scarce resources. And there's two arguments here. The instrumental justification is that if all the healthcare workers die, who are going to take care of the patients? And this is true, but a problem with this is that if a healthcare worker becomes sick enough that they actually need a ventilator, more likely than not, they're going to be weeks, maybe even months before they're going to be ready to come back to the front lines. Not always true, but somewhat true. And I think it minimizes this justification. Maybe a better justification is the reciprocal justification that healthcare workers deserve priority as a reward for the risks that they have taken. And I think that this is true, but then how do we think about other people in society that have also taken risks for our benefit? You know, the policemen who maintain law and order, the bus driver or subway operator that allows people to get around, the grocery clerk that makes sure that we have food to eat, the undertaker who does very essential roles in a pandemic. These people have also taken risks for the benefit of society. So if healthcare workers should have priority, why not them as well? And then finally, something that we haven't had to face, but I think if we do, it will be extremely difficult. And that is this issue of withdrawing life support from one patient in order to provide it to another. So all of the triage protocols that I have seen talk about that patients who have been allocated ventilators should be periodically reassessed to see if they are improving. And if they're not improving, or if they're getting worse, they should be removed in order to make room for another. And while this sort of a situation is not uncommon in resource-limited countries, even in the absence of a pandemic, it would be unprecedented in the United States. And I think it would be psychologically very traumatic, maybe even impossible for clinicians if faced with this, to remove somebody from the ventilator, knowing that their death was going to be imminent in order to make room for another. So those are my comments. And I think we go to you, David.
So I should begin my remarks with some disclaimers. I am not a credentialed bioethicist. I have never served on an ethics committee, whether in a hospital or on the state committee that produced the guidelines that Bob was describing. When I worked as a clinician as a psychiatrist, I was never asked to decide who lives or who dies, though as a psychiatrist, I was certainly involved in many rationing decisions of different sorts of healthcare goods. So I am definitely an armchair ethicist in this discussion, and I am second guessing the people who are actually doing this work. So I'm very aware of that. But I hope that my outsider position allows me to ask some useful questions. So I will ask three. First, are we talking about something that is actually scarce? As Bob said, most of the world has not had problems with its ventilator supply. In Italy and likely some places in New York City, there were shortages of ventilators, although it's very difficult at this moment to figure out how severe that problem was. I haven't been able to get clear accounts from New York of doctors who actively had to make the choice between two different patients. And as best as I can tell, ventilators have not been a scarce resource anyplace else. Seattle, which was both early to the epidemic and, as Bob described, a pioneer of rationing discussions, never had to ration its supply. Nor has Massachusetts, where we have been fortunate to have such a great healthcare system that our hospitals have only been running at about 50 or 60% capacity throughout the epidemic so far. And meanwhile, as Bob said, in New York City, there were many things that were in scarce supply: ambulance rides, personal protective equipment, dialysis, certain medications, and then proper space for the bodies of deceased people. So this makes me wonder, why have so many ethicists spent so much time arguing about ventilators? You know, what is the appeal of imagining shortages and imagining ourselves making these decisions? Now, it is certainly better to plan for this in advance, so we're not thinking for the first time about rationing at the moment when the decisions have to be made. But ethicists have been thinking about healthcare rationing since the 1960s, and they have clearly articulated the options and merits of the different approaches, as Bob has described. So it makes me wonder, is this new thinking actually required in the setting of COVID, or can we just use our prior well-established thinking about how best to ration? There's clearly some appeal here that draws people into these rationing debates, even when they might not be necessary. Some of it might be the excitement of imagining yourself making life or death decisions, Often the debates are phrased in terms of playing God, and this is something that seems to have captured the imagination of everyone who's involved. My second question is whether we are fighting about something that is actually valuable. Now, in the past, most discussions of rationing during epidemics have focused on medicines. For instance, much has been written about what we would do if we had a limited supply of a vaccine. Whom should we prioritize? But as many people know, at least from the flu vaccine, the value of this vaccine is hit or miss. Some years it works well, some years it doesn't work so well. And again, it's not clear if you had to ration the flu vaccine, whether that would be a life or death decision for anyone. And the same thing happens with medications. Again, for flu, there have been many debates about how you would allocate a scarce supply of an antiviral medication, oseltamivir. But again, that medicine doesn't work that well unless it's administered very early in the course of a case of influenza. And so all of this is to say that we have a very long history of having heated debates about rationing what are very low value interventions in the setting of epidemics. So now we find ourselves arguing about ventilators. And while the final medical results are not in yet, there are many, many reports of appalling mortality rates of people who are put on ventilators. It seems like 70 to 80% of the people who are intubated do not survive the course of illness. The vast majority of people with COVID who are started on ventilators do not survive. Now, of course, there have been dramatic case reports of people who do, and it's important not to forget that. But as a historian, it makes me wonder, there are very few things in medicine that doctors pursue despite such a poor outcome. A 70 to 80% mortality rate is really, really bad for medical intervention. The outcomes of patients with COVID on ventilators are worse than the outcomes of people who had gangrene, who had to have amputations in the early 1800s before surgeons had anesthesia or aseptic surgery. And that's often held out as like the worst thing that doctors ever did, with 50% operative mortality rates. Well, that actually looks pretty good compared to ventilators and COVID. So why are we doing it? Why is there such interest in ventilators such that we have discussions about rationing ventilators? In part, it's because some patients do survive. Certainly, if I developed COVID and respiratory failure, I assume that I would want very much to be placed on a ventilator in hopes that I would survive. And in part, it seems as though patients have no other choice. It's often presented as, you're sick, your lungs are failing, we have to try this, otherwise you will die. But I'm afraid that that isn't framing the decision properly. Offering someone with COVID a ventilator is not offering them a life-saving intervention. We are not actually choosing here who lives and who dies. Instead, we're choosing who will be given a slightly better chance of survival. And I'm not sure if that justifies the attention that this problem has received. Now, I think it's important for the armchair ethicists among us to ask these questions. So if ventilators are neither scarce nor useful, why so much focus on them? There are consequences of directing our attention to this issue of rationing ventilators. And it's an opportunity cost. As I said earlier, there have been many, many things that have been in short supply during this epidemic. Dialysis, masks, shields, especially testing to see who is infected or who has recovered. And I worry that our focus on rationing ventilators shifts resources towards ventilators and away from these other things that we also need. If we really wanted to save the most lives, which supposedly is the utilitarian logic of rationing, we ought to be focused on testing, contact tracing, and isolation, as those are the things that will likely save the most lives in this epidemic. My fear is that all of the focus on ventilator rationing has focused attention on high-tech healthcare and not on the public health measures that we needed to have implemented several months ago. And my third question is, why have ventilators and other medical supplies been so scarce during COVID? Now, again, there's an interesting history here. The federal government began serious planning for disasters in the 1950s as part of the preparation for nuclear war. It became clear during these simulations that the federal government would not be able to take responsibility for the civil defense of the entire population. The public instead was instructed to build and provision its own fallout shelters so that the people could take care of themselves. I haven't figured out yet when the government first started simulating pandemics, but it had certainly started by the 1980s. And many of these pandemic simulations have been done, and they all have the same outcome. Hospitals always run out of PPE and ventilators and everything else, and the simulation concludes that rationing will have to be done. None of these simulations have led to the creation of an adequate stockpile to prevent the need from rationing. Well, why? Well, my boss, Paul Farmer, would say that we are conditioned for scarcity. We are too willing to take scarcity for granted. We assume that it is inevitable and trust that we will be able to make acceptable decisions about resource allocation. Are there other ways we could think about this? And certainly. Instead of assuming that scarcity will happen, we could make the proper investments. We invest massively in a military that we never want to use, but we have not done the same kind of investments for pandemics. Clinton did establish the national stockpile, but that has never been adequate. State governments and hospitals have never seen this as their job, and we are now paying the price for this. Not so much in ventilators, but for the lack of testing equipment and other needed supplies. I've been thinking about this problem for many years and remain puzzled by the psychology. I suspect it would be far cheaper to invest in proper preparedness than to pay the price that we are now paying during this epidemic. But for some reason, we prefer to generate scarcity and ration than we do to invest wisely. And I hope that COVID will push us to think seriously about this problem. Thank you.
Thanks for inviting me to do this, Bob. And I wish that I had heard David's remarks before, because as both a good historian and a good psychiatrist, he's just suggested some reasons we may all be unconscious. Unconscious reasons we may all have to motivate our interest in this. But I'm still going to go back to the fact that we are motivated, and I'm going to talk about two things. One is the ethical issues that have been identified by the disability rights community and disability advocates. I think it's a fascinating story about the importance of doing bioethics out in the open so that various stakeholders can help to shape the public policy, and I want to tell that story in that way. And then I want to move away from the distributional justice issues that are concerned in triage to more structural justice concerns that the pandemic raises. So first, to the disability critique. You know, as Bob has clarified, nearly all triage policies aim to ensure that the maximum number of lives are saved. That's their point. And secondarily, there's some hope also to maximize the number of years lived. But the general orientation is a utilitarian one, that we should aim to create the most good or the most benefit for the most people, and that means the most lives saved. Mainly in the month of March, although a little bit before as well, there was growing concern among the disability advocacy community. They were aware that many hospitals and health systems across the country were developing triage protocols, and they were worried in particular about three things. They were worried about how survivability was going to be assessed. And they argued that basing priority schemes on long-term survival was first of all too imprecise. There wasn't really a good methodology for doing it, and that would open the door to implicit bias. So they were raising concerns about particularly long-term survival. But even some of the commentators went further and didn't think that survivability should matter at all. They were also concerned about categorical exclusion, something Bob mentioned. So for example, the worry that people with Down syndrome, for example, might be deprioritized just by the category. And then the third was that there was a concern that people might be deprioritized if they needed ventilatory support for longer than others because of their disability. And they asked for reasonable accommodations so as not to be taken off the ventilator too soon. One disability scholar, Ari Neeman, wrote in the New York Times under a headline, which sort of sums this all up: "I will not apologize for my needs." And he expressly called for stopping all policies based on survivability and using only a first come, first serve approach. Most bioethicists and public health experts agree that if you use a first come, first serve approach, you're going to reduce the number of lives you can save. And I think you may even make it worse for the disabled who might have transportation or communication challenges that would make it very difficult for them to be at the front of the line. Other commentators went even further. A Princeton professor, Alan Guelzo, called triage policies ghoulish and excuses for killing. As I was reading this material, I became concerned that there were very legitimate disability rights concerns that could improve triage policies. And at the same time, there could be some considerable overreach by the disability critique, which could undermine public trust in triage altogether. And then the sequel to that would be a result in more deaths. So it's been important that the disability advocates and the triage protocol designers have been engaging with one another. And they have been. In fact, they were forced to, because in late March, the Office of Civil Rights within the Department of Health and Human Services opened investigations into some of these state and hospital policies. As a result, for example, Alabama was ordered to remove categorical exclusions from their protocol, and several other states have followed suit. So I do think these protocols have been improved because of this critique. And I think it's a good example of the importance of doing bioethics in the public square. I don't think these improvements, which I'm about to describe to you, would have been made without an open public process. And that's why I was particularly proud that Harvard disclosed the potential necessity for triage in an open letter we published in the Boston Globe. Now, as to the critique itself, I think the most important point is the equal moral worth of each individual. That principle then drives the guidance that we shouldn't be making categorical exclusions and that we shouldn't allow third-party assessments of quality of life. There's a lot of literature documenting that physicians often view a disabled person's quality of life lower than the person herself. So patients' views about their own quality of life should matter, but not physicians. Furthermore, the Americans with Disability Act and also disability rights law makes it clear that this is not just about protecting people from discrimination, but also about making reasonable accommodations for people with disability. Ari Neeman, who I've already mentioned, also wrote a piece in the Hastings Center blog in which I thought he had a terrific analogy. He said, it's not that you can't put up a sign that says no wheelchairs allowed, because that would be discriminatory. But not putting up such a sign is not the only extent of your responsibility. You also have to provide a ramp. So I agree that we should afford people with disabilities a little more resource consumption, a little more time on the ventilator, but it shouldn't be an open-ended, limitless trial. Perhaps the most important thing I take away from the disability critique is that it rests on a far more robust notion of liberty than the negative liberty we so often stress in American individualism. Usually when we talk about freedom, it's simply freedom from something, freedom from interference, freedom from government intrusion. Implicitly, I think the disability critique is based on a more proactive, a more robust notion of freedom that recognizes that one is not free if one does not have the means to pursue fundamental life goals. If you can't leave the house, go to work, or participate in schooling, you really don't have a full, the meaning of freedom is really constricted. And that brings me to the final point I wanted to make. This pandemic has revealed the fault lines in our society that we have been talking about for decades. Not just people with disabilities, but poor people, people of color, and immigrants are all disproportionately getting and dying from COVID-19. Nationally, whites make up about 70-ish% of the US population, but only 40% of the deaths. While Blacks and Latinos together make up approximately 29% of the population, but 45% of the deaths. And when you look at other more specific statistics, it's incredibly distressing. In Michigan, African Americans make up 14% of the population, but 40% of the deaths. And we see similar patterns in New Orleans and New York City. These communities are experiencing a triple harm. As low-wage hourly workers, they're more likely to be exposed because they can't work from home or participate in a Zoom like this for work. They're less likely to have sick leave, and they're therefore compelled to go to work, and they have more underlying diseases because of well-known healthcare disparities. Bioethics loves to focus on important but relatively narrow questions of distributional justice. Fairness and triage is a good example. But as a field, we have been far less interested in structural injustices, like lack of housing for the nearly 500,000 homeless people, healthcare disparities that are making some of us die more than others, lack of health insurance, inadequate employee benefits like sick leave, and not to mention stagnating take-home wages and skyrocketing housing costs that have made the United States the wealthiest, but also one of the most unequal democracies on planet Earth. We are far more inclined to ask ethical questions about our rights than about our duties and obligations to one another. We rarely ask what a just society owes its members. I'm hoping that the pandemic might be a wake-up call to attend to the terrible inequities in our society. I don't know whether we'll use this moment, but I hope so.
Why don't we take maybe 5 minutes and maybe we can respond a little bit to each other, and then by quarter of, for sure, I want to make sure that we bring Dr. Bateman on as our moderator and get questions and comments from our audience. If I may begin, David, you had a lot of great points to make, I think, there. I feel a little bit slighted by this idea that bioethicists are somehow fascinated by these life and death issues and drawn to them like moths to a flame. And I guess I would say that, the best estimates by mid-March were that we were going to have a shortage of ventilators coming from the CDC. And as we say in medicine, we hope for the best, but prepare for the worst. And based on the information we had, I think it would have been really irresponsible not to have had a plan in place. And indeed, it was the disaster management physicians at Mass General and the Brigham that went to the governor and said, we have to have some crisis standards of care. We know that what happened in Italy, that they did ration ventilators and they didn't have a plan. And it evolved to simple age-based discrimination, which is certainly one way of rationing, but probably not one that we would choose. So I feel proud that we actually did have a plan. And I'm also proud to be a part of a city where we didn't need it, and where I think maybe even the very conversations that we were having about what triage would involve was one of the things that stimulated people to make sure that we didn't need them. So maybe just a little less of a harsh view about bioethicists, but nevertheless, I think the fundamental points are good ones.
Can I add to that, just to pile on before David? I think that I think leadership played a big role here, because in New York, Governor Cuomo mobilized because he said he just wasn't going to face the kind of choices that he saw in the protocols, and went into high gear and actually did bring in a lot of extra ventilators. So I don't think we've actually had to use them, but in New York, but as Bob just said, that was maybe because people were motivated when they saw the reality of these protocols.
No, I'm certainly sympathetic to that position, that the discussions of how awful rationing would be motivated people to respond to prevent it from happening. I mean, I wonder as a historian, the shortage of ventilators has been predicted since at least 1989. This wasn't a new problem. And where were anyone, disaster planning people, bioethicists, in January, last November, last summer, saying we're not prepared? Why did it have to wait until an epidemic? And then, but you could also make the argument about distracted attention. Yes, Bob is right that there was a forecast of insufficient ventilators. There was also a forecast of insufficient PPE, of insufficient testing and everything else. And we solved the ventilator problem such that there wasn't a shortage of ventilators. We initially did not solve the shortage of PPE. There was much care provided in this country, especially in nursing homes, and hugely inadequate settings of PPE. And we are very, very far away, despite assurances from the Trump administration to have solved the testing shortage. We are having massive rationing of diagnostic testing for this virus that is killing many, many people in this country. And why was there such a vigorous response about rationing for ventilators? Why hasn't there been similar outrage or debates amongst the bioethics community about how to ration diagnostic testing? Because that's what's killed the most people.
Scott and I were both on the DPH task force, so shared that experience, and I thought he'd make a great moderator for us. Scott,
right.
Take it away.
Well, I asked the organizers of this if there's going to be a chatty group, and there's been a string of questions that have been generated. So my job is going to be very easy, just trying to call through all these questions. It was great to listen to you all. I've been thinking a lot about this, and it's inspiring to see you guys spend a lot of time to focus on these really important issues. I'm going to jump right into a question that came. Can you comment on the Trump administration member, Roger Severino, who's the director of the Office of Civil Rights at the Department of Health and Human Services, who claiming that utilitarian standards were unethical and that his office would seek legal action against utilitarian allocation? So I guess really, can you contrast why utilitarianism versus kind of first come, first serve actually is a more ethical approach in a rationing situation? I know Millie mentioned it a little bit, but maybe you could say, what is it that makes it ethical or unethical? Someone's claiming it's unethical.
I'm happy to jump in, and then I'm sure Bob will have something to add here. I thought that that kind of comment is what concerned me, because I think it's not, utilitarian approaches are not unethical. They're basically trying to maximize the number of lives saved. And the disability critique attacked that goal as being utilitarian and saying that it was in contrast to an equity approach, which was a label they put on what they were requesting. And I felt that that's an unnecessary opposition, that utilitarian approaches do not have to be done in an equitable way. And so I've been trying to articulate the ways in which we could take the best and most important of the disability critique into triage reform without without overreaching. So to call all utilitarian approaches unethical is just, that makes no sense. The whole purpose of this is to save lives, and I don't think that's an unethical intent at all. We just have to be careful to do it in a way that doesn't make categorical exclusions, and that doesn't evaluate people according to third-party quality of life assessments about them, and that respects the equal worth of everybody. And I think it is possible to do both, and it's been a very unfortunate labeling.
Maybe let me chime in as well. So the alternative of using some sort of a scheme to maximize lives saved would be a lottery. And when we, in situations like this, what a lottery looks like is first come, first served. It's based on the idea that the order in which people become ill and present for medical care is a random event. And so first come, first served functions as a sort of lottery. And yet the inequities are just absolutely baked into that. Those who have quicker access to a hospital or who get referred earlier are going to have advantages over those who don't. And those who don't, again, are going to be vulnerable populations. So it's not going to treat them fairly. And, particularly for a disease like coronavirus, where patients are, those who do survive ventilation are often requiring 2 or 3 weeks of ventilation. Once all those ventilators are just used up at the beginning, first come, first served, and then they're all gone, everybody else is out of luck. And I can think, for those people that never had a shot at it, I think they have a very good claim that they were not treated fairly. So it's just not obvious that alternative approaches are better than the ones we've come up with so far.
Dave, you want to comment on that, or should I move on?
I'll just say very briefly that, and as this makes clear, we're not choosing amongst desirable options. I mean, any of these scenarios leaves a lot to be desired, and it's just a rotten situation to be in. Again, it raises my earlier question about why is it that we don't do a better job stockpiling and preparing to avoid this to begin with?
All right, another question that was posed was, considering that most vulnerable populations, some minorities, homeless, have poor health outcomes, is the pandemic situation the moment to try to compensate for this disadvantage? What do you think to that? Should we really be colorblind in our situation towards allocation if this is a certain situation where there's such a disproportionate number of minorities being affected?
I mean, I'll say one thing initially here, and I'm going to start to sound like a broken record. But again, this was about the most predictable thing that could possibly have happened in an epidemic. I spent the first half of my career doing research on health disparities with infectious disease. And for as long as there have been Europeans living in the Western Hemisphere, so for over 500 years, there have been observers of health disparities, whether it's between whites and American Indians or between whites and African Americans. And whenever there have been epidemics, there has been higher mortality amongst racial and ethnic minorities and higher mortality amongst the poor, as Millie had described. Any person with even the worst functioning crystal ball, the minute the epidemic started, should have been expecting that this is going to happen. And I was watching this unhappily play out in March and wondering where were the discussions of race, and then sure enough, they've exploded since April, initially with disparities in African Americans, and now with the terrible epidemic on the Navajo reservation. I think it raises the same question. Given that we know so much and could have predicted this, where did we go wrong? Why didn't we take measures in advance of this very foreseeable outcome that might have mitigated the racial disparities that we're now suffering in a big way?
But Millie or David, I mean, you could also read that question as, is there a place here for affirmative action? Is there a place for actually prioritizing the vulnerable for all these reasons?
I think there is a place for it, but not necessarily around ventilator rationing. I think there's a place to be building special facilities for the homeless that we have to be developing. We're still ignoring what's going on in nursing homes, and as far as focusing on specific ethnic neighborhoods where we would, if we would, learn where the hotspots are, where we could put human resources to do contact tracing. And I would privilege those lower, socioeconomic and racial neighborhoods, because we know they are hotspots. But to David's point, the things we could do to really bring this under control, we're still not doing. We're not ramping up the contact tracing, which is absolutely essential, and that's dependent on the testing. So I agree, David, that this is one corner of bioethics, but there's a lot more to be done around the infrastructure issues that would let us take hold of this pandemic and manage it, and it's not happening. And that should privilege those who are suffering the most, which would be those communities.
All right. One of the questions was, how is the public going to accept these allocation standards if they're enacted? I mean, our culture does not have a collective good over individual liberties or rights as a grounding principle. So does the appeal process actually allow those individual rights back in? And is that going to bog down the system and kind of essentially create problems down the line? Or is that really what we should be doing?
Well, I will say one of the points that was really emphasized by the governor's office and Secretary Scudders here in Massachusetts was that there needed to be an appeals process, number one, and then also there needed to be robust oversight so that on a real-time basis, there would be a committee with broad representation that would be looking at the decisions that were being made and looking for evidence of systematic bias and correcting it in real time. And how those would have played out if we were facing it, I don't know. I could imagine it paralyzing the system. If people felt that they could not move ahead with decisions until an appeals process was completed, and that maybe could take, many hours or days. One of the advantages, I think, of having created the draft is that I think we have a better idea of all the ways that it could absolutely fail. And we've got now time to think about that and maybe ways to make it better.
One question I had been wondering about, and I suspect Bob or Scott would have a sense of this, how would the appeal work? Because in theory, the person who has been denied a ventilator is someone who is near death and away from their family and friends because of the isolation precautions that hospitals have in place. So who would there be to appeal on behalf of this person?
Well, actually, I think there's a good answer to that, because the triage teams are separate from the clinical teams. And I think what was envisioned would be that the clinical team, if the family wasn't there, their job would be to say, wait a minute, you're not considering factors X, Y, and Z that you need to take into account. Granted, not perfect, but I think the separation of roles is somewhat helpful here.
All right, so Bob, you touched on this in one slide, but it came up a couple of times in some of the questions. The question is, some physicians were extremely concerned that they were not going to be prioritized for ventilators if needed. How ethical is it to ask for protected status because you are a physician or nurse or healthcare worker?
Well, I'll speak a little bit personally about that, and Scott, as well. I personally feel it would be entirely wrong to prioritize healthcare workers. It looks for all the world like a policy made by doctors for doctors. And yet, on the other hand, there are absolutely strident voices out there that I'm not going to come to work if I don't know that I will be protected in that situation. Of all the things that we talked about, Scott, and I think you'd agree, this was really one of the most contentious.
Yeah. Melly, do you think it's ethical for a physician to ask for protected status, or a nurse?
I think that healthcare providers, the default should be that they're going to serve. But the exception to that is if there's been a moral failure on the part of institutions to provide the correct personal protective equipment. So if we've been seeing situations just with, asking people to really sacrifice themselves and go into terrible life-threatening situations. And under those circumstances, I don't think they have a responsibility to do it. I just think that's wrong. And if it weren't a situation of scarcity and the equipment was available, they would have the obligation to do it. Under these scarcity situations, if we're going to, I agreed with something Bob said, I think it's not only healthcare workers who are putting themselves in harm's way without protection. And while it would get difficult because many people would want to make claims that their role was essential, I don't think it's fair to only allow the exception for healthcare providers when bus drivers and grocery clerks and fire people who arrive when you dial 911 are equally putting themselves in harm's way. So, the real answer to this is to address the scarcity problem to begin with. And could I address a question to David as a follow-on to this?
Sure.
So David, you've asked this question repeatedly. And as a psychiatrist, you offered a sort of a psychiatric response that maybe we enjoy playing God. You said Paul Farmer thinks we humans are maybe conditioned for scarcity, but might it just be that people didn't want to spend the money? We've known for decades now. The National Academy of Medicine came out and urged that we do stockpiling, and there have been all kinds of wonderful intellectual thinking about the problem. It's all been sorted out conceptually. We've got national reports. All the thinking's been done, but none of the action took place. And that action required leadership, and it required a willingness to spend money on something that was uncertain to materialize. So let's answer it bothers me that we would come up with a psychiatric explanation when there might be just a practical, or I don't know, let's generate all the possible answers. And then what do we do next?
Yeah, so there's a lot to say there. Before answering that question, just one quick comment on the previous discussion, what are the obligations of physicians? Again, speaking as someone from the comfort of my home study at very low risk of getting reactivated and put in a COVID unit, I can imagine what a stronger argument for physician obligation would be, which is that the state has given physicians a monopoly on the practice of medicine. And with that monopoly comes an obligation to practice even at risk. And if, as Millie said, it's not fair to ask doctors to work in substandard conditions, given that to the most part, physicians control hospitals and physicians are responsible for the lack of PPE in these hospitals, it's a mess of physicians' own making. Again, an academic argument, I don't think I would support that argument, but I can imagine how it would look. As opposed to what's going on, I mean, yes, all roads lead back to money. Money has something to do with it. It's a very subtle issue because there are some avenues in which we do prepare things. For instance, every time there's a whiff of influenza, basically orders that are baked into the federal systems lead to massive stockpiling of oseltamivir. And that's a very muddy story about financial conflicts of interest between Roche Pharmaceuticals and senior officials in the previous Bush administration. We do spend gobs of money on military in the expectations that we never use anything. So there is money to be spent when we value certain things or when the wheels of government align in such a way that we're willing to spend loads of money stockpiling a pharmaceutical, a profitable commodity for a well-connected industry, and that we don't do similar things. Now, some people will say, well, the reason we don't stockpile for pandemics is you don't know if it's going to happen in 1 year, 5 years, or 50 years. And so why spend money on something that might be perishable and rot on the shelves of the national stockpile? But we do spend money to stockpile medications, and those are very perishable, much more perishable than N95 masks. And obviously we spend lots of money on the military. So it's really a question of value. We value some things more, and then we allow, and whether it's corruption or something else, we allow financial interests to lead to some decisions that have not led to stockpiling. And then the other issue that comes up is one of divided responsibility. The federal government clearly, the Constitution clearly assigns the federal government responsibility for the military. So the federal government understands it has to do that. The federal government has never, with the exceptions of niche areas, the VA, military medical services, Indian Health Service, the federal government has been loath to take responsibility for direct patient care. It funds care through Medicare and Medicaid, but the federal government is not directly involved in primary patient care except in a few select settings. Well, who is? State governments historically had run massive hospitals, but the state hospital systems have been greatly curtailed since the 1950s. And as a result, we leave direct patient care to private entities, most in Boston, nonprofit hospitals, but there are a lot of for-profit hospitals out there. And have these private entities felt the obligation to society to be the backstop in the setting of an epidemic? And the answer seems to be no. And so I think what someone needs to do is make a clearer argument. Who does have responsibility for this? Are we going to tell a hospital, if we're going to license you, you need to have a 6-month supply of PPE in some warehouse somewhere? Or are we going to say, well, no, this is really the role of the states, and they need to take all their state hospitals out of mothballs and have them ready for surge capacity if needed? Or should the federal government act and say, we're going to do an honest to God job with a national stockpile such that it's not exhausted within 2 weeks of the next pandemic? A decision has to be made over who is responsible. And then if we value this, the money will follow. There's plenty of money. It's just not being spent.
All right. Well, I want to respect everyone's time. Our hour is up. I want to thank my friends, David, Millie, and Scott, and also everyone out there. It's a bit weird when I can't see you and everything else, but I appreciate your spending part of your evening with us, and I hope you found the discussion interesting and maybe somewhat helpful. Jonathan, do you want to close us up?
Yes, thank you. Thank you, Bob and David, Millie, and Scott for all of your work. And thank you, all of you, for joining us. This is one of the signature events of Socialize Remotely. We hope you'll log into more of them. Information can be found at socializeremotely.harvard.edu. Good night, everyone, and good health.